Thank you, Wendy. Good morning, everyone. Buenos dias. I'm happy to be here, and I'm even happier that you guys are here. This is our second annual event, and we're going to keep going. I want to start off with one question, just a show of hands. How many of you want to age? I've actually, on one occasion, I had someone just raise their hand. So I was like, maybe you didn't understand the question, maybe. Anti-aging medicine, longevity medicine has come a long way. We're doing so many things that still need to, we still need to spread the word about what's going on. And I know historically, when people spoke about anti-aging medicine, they would think about aesthetics and the hormones and all that. But we're doing and that's always part of it. But we're doing so much more right now, and that's the whole idea behind this sort of event. I mean, I want you all to be immersed in what we're doing: nutrigenomics, senolytics, telomeres, peptides, the works, and it's all part of a greater plan of really addressing the root cause, which is aging. Before, we thought aging's inevitable, but it's not. We can modify it, and we can reverse it. So that's the purpose behind what we're doing in Camas. And I'm glad you guys are all forming part of this. And there's three things that I think you can take away from this sort of event. The first one is obviously the knowledge, the presentations. We have amazing speakers. And I'm sure you guys are all going to enjoy the program. So the speakers, the information you're going to get out of this today is really, really valuable. Also, the network and the network of like-minded physicians. I think it's really important for all of you to connect. When we're venturing into longevity medicine, into anti-aging medicine, some practitioners that are starting out might feel, a little concerned, confused, scared. I mean, is this right? What am I doing? And I think the network of professionals is just really important because you can feed off that. And you can grow and you can learn. We're all learning. Whenever I'm exchanging ideas with Dr. Lee, Dr. Dinetz, Dr. Gonzalez, Dr. Reese, all of the speakers, we're all learning. We're all doing new stuff, and we can always fine-tune our knowledge and practice. So that's that. And then the third point that I think is really valuable from this sort of event is also getting to know the companies, the sponsors, the people that will provide you with the tools to be able to do what you guys want to do. I mean, the compounding pharmacies, the labs, the equipments, machines. There's a lot of stuff that we're doing, and you need to incorporate. You need to have a good toolbox, and that you can get from all these companies. So I think it's going to be a great day, full of energy. We're on island time, so we're a bit more relaxed, which is not good. Wendy gets stressed out because we have a really, really intense agenda, and I get that. But we'll relax. It'll flow perfectly well, and our telomeres will get longer. So having said that, again, welcome you all, and I'm going to introduce our first speaker to start things off, Dr. Elliot Dinetz. He's a double board certified in family medicine and functional medicine. And I think he understood from an early age this was what he wanted to do. He is also advisory board member for Age Management Medical Group. We're both on that group. Dr. Lee is also there. And he serves also as medical advisor for Forbes Health. He writes articles. He's a contributor. He was an early adopter of clinical genomics, understanding the benefits of applying precision medicine, personalized medicine to his practice. And, he dedicates his practice to what we're doing here. He's based out of Miami. And outside his practice, he's really engaged in lecturing, training, educating, in everything, aging, research, clinical genomics, and all that. So I'd like for all of you to welcome Dr. Dinetz to the stage.
Hello, everyone. Can you hear me well? All right, perfect. So I just wanted to say it's an honor and a privilege to be here yet again, second year lecturing here at the Advanced Anti-Aging Summit in Puerto Rico. It's always amazing to be here. Have a great time every single year. So here's how we're going to start off the day. I think that it's a really good topic because you're going to hear amazing speakers, okay, about how to conquer aging. So as Dr. Martinez mentioned, hi, I'm Elliot Dinetz, and I'm a functional medicine and regenerative medicine physician in Miami. The topic of today is matching DNA with interventions for a most personalized and precision approach to medicine and longevity, and particularly in using genomics for optimizing weight and reversing chronic symptoms and disease. Talk about how to really lengthen people's health span and telomeres, right? So this is what I got into early on, and I find that it's a cornerstone in my practice. So I'll be happy to entertain questions after, but I know a lot of people are new to the clinical genomics field, or maybe not. Raise your hand if you use this. Genomics in practice. Great. So there's a lot of people who are going to learn a lot of stuff today. And I will take it step by step, very slowly. All right, I have no financial relationships. So the learning points today are as follows. How to avoid trial and error when optimizing health. I mean, that's medicine, right? But if we can take a shortcut to helping people, or if they're not getting better, genomics serves as a scaffolding, right, to our makeup and how we can see not only our strengths, but our risks and how to address them on that level. We also are going to avoid assumptions based on lineage. I always say this because I trained in Georgia, okay? And I have a lot of patients who used to say, my granddaddy lived till 100 and he smoked and drank every day. And I didn't know what to say then. But today I know what to say. I said, I hope for your sake you won the genetic lottery in that aspect. Because if you don't have the right genes to detoxify from those things or limit inflammation, you're going to have a problem. All right, we're going to avoid confusing new fads and knowing what's right for every body type and what genes are crucial for diets and labs, okay? So the new frontier in personalized and precision medicine. Here we go. What's a gene? Most of us know that already. It encodes for a protein, and proteins are what make up cell-to-cell signaling, enzymes, and the structure of our cells, right? The genome is the entire makeup of our DNA, and we have an exposome that's really expressing within that. But the crux of today is alleles and SNPs, all right? So an allele is literally a variation in that particular gene. That's really all it is. So you have different alleles for genes, such as blood type, right? Your ABO type, whether you're AB, O positive, thalassemia, right? And we know that can be a problem depending on which type you may inherit. But these are all encoding for the same proteins, just different things can be a strength or a risk. Eye color. That's not a strength or a risk, but that's an allele, right? You can have different eye colors, right? And each allele can basically essentially be a SNP, or single nucleotide polymorphism. And what these are the variations in the genes, okay? So I gave a good intro there, and this allows us to have something called N of 1 medicine, or the study and treatment of you, right? Instead of the study of multiple people who have different backgrounds and lifestyles and all the limitations that studies have. But this is what allows you to really optimize health for the individual. Dr. Martinez, Dr. Edwin Lee, a lot of my colleagues, and many of you are interested in the future, which is transcriptomics, proteomics, and everything. And I think it's the next frontier. But this is serving as the foundation of that. And the overwhelming evidence is here. So they're called GWAS, or these genome-wide associated studies, that allow computers to read this. And they can read these with people, hundreds of thousands, millions even, our studies are coming out, just to look at what these genes or variants are doing. so that we can really see, oh, I see the connection there. If we can address this, or we know what people are going to be at risk for, we can help save their life. So let's talk about obesity. It affects over a third of the population. I think it's almost 40% now, since I made this presentation. What's crazy is overweight and then obesity and everything else is 70%. 70 in the States. I don't know about here, but 70% of people in the States. And it wasn't like that just 50 years ago. It was like 13. So we know genes don't change, right? So what has? Well, we'll talk about the differences in heritability and why certain people get obese while other people can eat cheeseburgers all day and fries and whatever, and they don't gain weight. When we look at this, what we find really interesting is that, yeah, about 40 to 70% of people have genes that actually regulate whether or not they'll get fat or have obesity and visceral fat deposition near their organs. But a common misperception is exercise is going to help me. I'm going to go and exercise until I pass out. But we already know that for the past decade or so, it doesn't work like that. Okay? Meta-analysis show that even compared to behavioral changes, exercise, and lifestyle, comparing that plus, diet as a component of lifestyle changes, including exercise, made very little difference up until about a year, and then it was slight. But you'll see, certain people do respond to exercise better than others, and you can guide them. So let's talk about the first gene that I find pretty important. That's why it's called STAT3, STAT gene. This one is present in about 40% of populations, but becomes a concern when you have two or more of these alleles, right? One from either parent in an autosomal recessive way. And it signals the hypothalamus, to say, hey, I'm full. And also regulate energy metabolism that's related to body weight. So particularly in response to saturated fat. All right, so saturated fat can be inflammatory. We know that from the age management literature, but particularly in these guys with such variants, okay? The variants are not the wild type, meaning the majority of the population in these cases. So having two or more we talked about, and red meat and dairy are the most common sources of saturated fat. So let's look at some of the literature we have from the Journal of Nutrition. Here you see your odds ratio. If you have one, like 40% of the population, or no gene variants in that pathway, you have no risk from that standpoint of saturated fat. Then as you have two, you look over there and you actually start to increase your risk about double. And if you have 3 plus, you can actually reach an odds ratio of 3 or threefold the risk of obesity in those who are expressing it. So very interesting to think about. Here's another one. I like this FTO gene because it's one of the first genes they found relating to obesity. And I make things simple. I say fat turns on when I see that one. That's how I call it. About 16% of people have 2 variants, which carries a threefold risk of obesity. A lot of women, it's shown to express higher in, and it's involved in fat cell differentiation. Yesterday, we had a wonderful talk by Dr. Martinez in the peptide conference, where he talked about visceral fat versus, non-visceral fat and brown fat. Well, this is actually a gene that helps regulate where the fat's going to be depositing, and you have more white fat with this gene variant, and you have greater appetite, but you also have weight loss with exercise if you have more, 2 or more variants. So that's very interesting. So what can these people eat? What's right for them? We knew about STAT and saturated fat. What about FTO? What's really cool is if you look at the bottom, according to studies, with this gene, they can obtain more benefit from 3 things: exercise, calorie restriction, so not eating as much in a meal, and high protein. So these are your high protein guys. We have another gene called LEP, or it stands for leptin. Who's heard of leptin? Okay, so that's a hormone that goes from our enteroendocrine hormone from our gut to the brain saying, hey, stop eating, you're full. Well, with this gene that a third of the people, almost a third of the population have, interestingly enough, with 2 copies called homozygous, is that you have larger leptin and more leptin resistance thereby, so you're not going to feel that satiety or fullness when you're eating. So interesting, when you have that C allele, it's become associated with these issues. So snacking becomes a problem, and people don't know how much or when to stop. So I found this article very interesting. Obesity and infectious diseases, okay, an epidemiology of a double pandemic. So we had a pandemic of a viral effect on killing people and making them sick and chronically ill, right? We've dealt with this. But obesity was the #1 risk factor. And this article points out something in common. Vitamin D deficiency in both populations. And if you haven't heard, you can talk to me after. There's a great publication that came out showing a theoretical risk of 0 with COVID if your vitamin D levels were a certain level, which was above 50. So very important that we always look and check and prescribe this, as Dr. Edwin Lee talked about yesterday in peptides. So let's talk about some cool cases I've seen and I lecture about because it's made a difference in their lives and all of us. We have a 44-year-old female, white female, with some truncal obesity. I like this case because I told her after I found out about this, I'm like, I'm using your case as a presentation. She's a health coach, okay? Didn't know why this was happening. She wasn't perimenopausal symptomatically yet, and she just went from 120 to 160 pounds in her 30s and kind of lingered there for the past 15 years. And she says she hadn't changed much. Her breakfast had some low-fat yogurts, but other dairy products throughout the day, right? So what are you thinking? Saturated fat, right? And she had meat and lots of fruits and veggies because she's a health coach. So not really a drinker other than borderline hypertension or high blood pressure. She was taking no medicine, but she knew something was up. And she couldn't figure out what. You see here her labs. Fasting blood sugar ranged between 90 and 95. So her A1C, though, was 5.5. Cortisol wasn't a major issue in the morning at 9. Her TSH and free T3 and free T4 respectively are shown here. Not suboptimal. And the insulin could be a little bit better. So she already tried doing some intermittent fasting, didn't do anything for her. So she wanted to see what her genes showed. There you have it. She's got 2 STAT3 genes. So now we know saturated fat is not in her best interest. And studies show that under 10% of your daily calories, if they can be saturated fat kept in that range, you can lose weight. So she did that for 6 weeks and 10 pounds came off. So I told her, I'm using you as a presentation, okay? She had no problem with it. And now she helps people with genomics. All right, our second case, I think is pretty interesting, is a 25-year-old female. She came to us from a town south, a rural town actually, in Florida, and she was diagnosed with bipolar. So her psychiatrist referred her to our clinic because there was no other medication she could take other than Clozaril. Does anyone have experience with that medication? Big time weight gain, voracious appetite, and just slows the metabolism. So it was a struggle because she couldn't get off, but we had her in the process of weaning down. So we helped her out with some semaglutide. And while that helped, she lost 30 pounds. She's still significantly overweight at 200 pounds with that. And we plateaued. So we needed more help. Her mother was super supportive. She's like, let's do this. What can we do to help reduce the obesity here? She's finally gotten control of her mental health. So we looked at her genes. And yeah, she had 2 STAT3 genes, but look at them. She had 4 total alleles. So saturated fat was in her diet. We cut that right away. But that's not all. She had FTO as well. And look at those other ones. She had other alleles as well. The red just means, in that particular gene, it showed the odds ratios were far more than 2. You can see in the corner 2.79. So really, we know saturated fat's one part of it. But she's also got concerns with caloric restriction, no problem. They agreed to. The second one, of course, is more protein, no problem. What's the other thing that she needs to do? What? You guys got that? So it didn't work, what we were doing for her, because I was talking about nutrition. Turns out, that's how much exercise she was doing. Literally, the girl wasn't even walking. Only until she started to do that, okay, the plateau stopped. So here you can see how exercise is important for certain people. So if you want to know who, it's kind of here to tell you in the genes. So then she started moving closer to her goals, thank God. She's doing great, by the way. Case 3. A 45-year-old white male with truncal obesity. He's a busy executive. He's actually from Brazil. And he's like, I want to do my genes and see what's going on with me, because ever since I hit 40, I've been a little overweight. And we took a look, but first he told us a little about his history. And he was always thin. He's like, Doc, we're the same body type, all that stuff. It's just, I'm packing on more over the years, and I don't like it. So the only time he was perfect, when I was asking him questions, or where were you happy? He said when he was eating a more balanced diet, whatever that is to the person, and a higher activity. So it's been a struggle, and he kind of wants to be, ideal at 175. He was hovering around 190s. So your typical patient, no one sick, just someone who wants to be optimized. And we looked at his genes, and he had the FTOs. He had 6. It's the most I've ever seen. But he also had leptin. So I said, tell me about how you eat. This is something that a lot of people will see. Well, I don't eat breakfast. Then I have lunch. Okay, it's not too much. It's protein. Saturated. I have a little saturated fat. It's meat, salad. But Doc, I entertain clients at night, late at night, and that's when I eat. Okay, so he's eating high caloric foods at night. FTO doesn't work well. He does exercise, but not enough, maybe 1-2 times a week. And we all know 150 minutes a week is minimum. Okay, that should be 5 days, 30 minutes, or 45 minutes. So we knew he could pick that up. But the foods he was eating were also highly fatty at night, high amount, and he wasn't doing enough exercise. As simple as that. And the leptin means he can't control how much he's eating. So the night he was fighting me with this. Even with his genes, I'm like, this is what you have to do. So we had to use health coaches and help us and kind of orchestrate his lifestyle. So he'd still go out and entertain, but instead of boozing as much as he did in the saturated fat, we curbed it to a lower caloric, higher protein meal, and he left me alone. All right, he started getting where he wanted to be, and he's happy. And he knows at the flick of a switch, he knows exactly what to do for a wedding or a party in 4 weeks, and he gets to where he needs to be. So that's interesting. Now we'll move on to incretin and weight. Does anyone know what incretin is, by a raise of hands? You guys all use this medicine, so it's interesting. Incretin's these hormones. So I like this diagram here. You can see as we eat, the food comes into the stomach, and we secrete GLP-1s, right? That's the medication, Ozempic that everyone loves, and terzipeptides and everything. And you also have gastroinhibitory peptide. And what these do is they signal the fat how to deposit or not to deposit. They tell the pancreas, hey, secrete more, digestive enzymes. Food is coming, right? But interestingly also, it slows gastric emptying. It stops gluconeogenesis in the liver. It helps with, these are important hormones for fatty liver disease. So I wouldn't be surprised if a lot of people have fatty liver disease with some variants in that signaling pathway and why Ozempic has been so successful. all right? And it also tells the brain stop eating. So here's a cool gene. It's called TCF7, okay? That's what I call it. And it confers the risk for type 2 diabetes because it doesn't allow that incretin, that ability of your stomach satiety and hormones to secrete. It's just not there. So you're not helping the pancreas, you're not helping your brain, your liver, and everything like that if you have this. Defective insulin exocytosis. This is the real message you want to hear on how it works in the pancreas. You can't secrete insulin. So these are the people who have low insulin in your practice. You ever see those? And they have high blood sugar? If they have carriers of that gene. So some studies show, not only regarding blood sugar, which we would assume is a problem, but those who consumed 20% versus 40% fat, okay, showed significant weight loss. Now, what's a really popular diet that would not go well with that? Right. These people don't do well on keto, or as well. So it's interesting how you can take your genes and show somebody, maybe, besides lowering sugar, keto wouldn't be so smart for you, possibly a little more on the protein versus fat. And we also know time-restricted feeding improves blood glucose, right? Intermittent fasting, especially at night. My patients, I tell them to avoid grains and carbs at night. I don't care what your genes are, and it helps. They've shown, I love this study, it's a case series. I published case series before, and I find them helpful to look at, that people just doing that got off their insulin. Intermittent fasting, especially if you're doing enough to get to autophagy and have that self-breakdown and rejuvenation aspect, can actually repair the pancreas, and we can reverse diabetes. So what else can we do for people with that gene? Well, there's supplements like Gymnema sylvestre. This supplement actually is found to prevent absorption of sugar molecules in the intestine and leads to a reduction in blood sugar. So let's take a look in a case that I had. Okay, 38-year-old physician, body mass index 21, presents with an increasing fasting blood sugar and A1C. Active daily, okay, daily is an exaggeration, 4 to 5 times per week. No junk food, no heavy bread, but has desserts sometimes. If you can't tell, I'm talking about myself. This is my case. So late dinners, sometimes with meat, sometimes with pasta. Denies all other symptoms. I was scared with that insulin, with an A1C going above 6 in myself. I was a little concerned, okay? It went from 5.6, which was already not great, to 6. I don't have any blood dyscrasias, any reason for my A1C to be off on my red blood cells, but my insulin's also going down. So this is when I was actually coming to the realization of clinical genomics in my practice. And my colleague was like, who created this panel and published, which you'll see soon, she's like, we need to check. So we did. Fortunately, I didn't have GAD65 antibodies or an autoimmune condition, but here are my genes that I don't have a problem showing everyone. So I had this pathway, and sugar is not my friend, and no, I wasn't doing keto. So what do you think I did? I said, I'm not doing supplements or anything. I want to do this just nutritionally. So here's my trends. I started to intermittent fast and not have those desserts and not have carbs and pasta at dinner, and it started to come right back down. Okay, I better be at 5.4 by now. That's all I'm going to say. But it was really that simple for me. I didn't have to take, supplements, but I probably was about to, right? And I might consider it if I eat like that, if I travel to Europe or something like that. So interesting. Moving on to another case. This is a more recent case, so I continuously update my presentations. This is one of the sweetest people I've ever met, 67-year-old white female, body mass index of 35, and she trains 5 days a week. She's built like a horse, really strong, okay? But she has issues losing body fat. She's from Pennsylvania, has eaten right for a few years, and she has a registered dietitian and trainer. both in Pennsylvania and in Miami on the same team. So she's got everything going for her, but they can't get her to lose weight. So she trains, she's low on carbs, she eats periodically throughout the day. Strong family history of dementia, though, and weight. So she goes, let's do this. Let's see what's under the hood. Let me see what I have that can help me. Well, she's 67, right? So she's postmenopausal. I also always screen patients. Don't let them go by your office without screening for sleep apnea. I catch it all the time, and you can't lose weight if you have that. You're going to get demented if you have that. There's a lot of risk factors with sleep apnea. I mean, you're suffocating, right, for several hours a night. It's a serious thing. Arrhythmias, most arrhythmias, I will say here, most tachyarrhythmias you'll see are from sleep apnea that's not diagnosed. So we looked at her labs. Okay. Look at this, where I put the arrows for you guys. I don't need the laser. Her cortisol was a little high from work stress. Okay, that can certainly lead to obesity. I thought her reverse T3 was a little high, which means that your thyroid isn't really converting from T4 to T3, but into a competitor and not allowing it to get in the mitochondria. Insulin was actually, not terrible, but not terribly low either, not high. And I'm thinking, okay, let's look at her ultrasounds. And we did a liver ultrasound, unremarkable. Surprisingly, I thought she would have fatty liver, but her nutrition was apparently accurate, right? Because we know carbs lead to fatty liver disease. That's one of the biggest culprits. So we worked on this, right? Just said, let's start you. We know your postmenopausal hormones are deficient. We started her on a low dose of bioidentical hormones, and we addressed the stress. So she worked on this, meditation every morning. She's the best patient you can ask for. She does what you tell her. And, minimal weight loss. Nothing scary. Okay, the hormone labs were now detectable, but still she has room to go. She's not tired in the afternoons anymore, which was something she told me. She has more endurance with lifting. She feels great. Not disappointed. But I was, because I want her goals to happen. So we tweaked up the hormones. Okay, we waited another couple months, and still no improvement. A little bit more. So what did we do? We obviously at this time we're looking at genetics. And I'm not looking in her obesity pathway in the genes this time. This time I'm struck by, she's got risk for Alzheimer's. This is you don't see this very often. She has 2 of the genes, so she's homozygous for Alzheimer's dementia. She's 67. All the relatives she had were far younger because she's working out, eating right. She's doing that stuff. And if you don't know this already, estrogen actually rejuvenates neurite outgrowth in the brain and cleaves beta amyloid. So I feel like she already did a lot of the battle. But again, we're talking about weight here. But I said, this is an interesting gene I don't see very often because I'm always learning with genetics. Tom40. Has anyone heard of that gene? All right, I had not until probably a couple years ago, and doing this for 5 years now. The past couple years are interesting. I haven't seen it until her. Look at that odds ratio. I mean, that really increases dementia. Okay. Enough with the dementia. She's here for weight loss, right? So I looked into it, and here's what I found. In a systematic review, okay, it actually correlates with, is associated with body mass index as well as cognitive function. It's a mitochondrial gene. So what you're telling me is this person has a mitochondrial defect, and this could be relating to her fatigue, weight gain, and metabolism. Interesting. So what do you think I did? I went back to the drawing board. I'm like, okay, let's optimize this person's mitochondrial health. So per the literature, and I cited it right there for you guys, here's how CoQ10 can help both mitochondria and metabolism. Carnitine is well known at higher doses like this to improve metabolism, okay? It gets into the inner membrane of the mitochondria and it burns fatty acids, and her eyes lit up. She goes, that one for me. And then we put in NAD in the form of NMN, okay, as a precursor to NAD to really help rev that engine and get NAD to NADH ratios higher and rev the engine of the mitochondria. I also add phospholipid complex. In anti-aging literature and conferences, there's a lot of talk on phospholipids because you need the membranes of your cell to allow these things in, as well as the membranes of the mitochondria. So I added these things for her. As you know, her thyroid's important, and it goes into the mitochondria activated to work, so we needed to optimize that, plus her hormones. And finally, as of literally last month, okay, we've been working together several months, we started to see some improvement, and my colleague who wrote this said, it's in the literature now. You need to use this to guide yourself as a clinical tool to help patients achieve what they want, and it works. So finally, 10 pounds down, maintaining muscle and strength, routine training. She already felt good, but she was like, you got it. So we're there. We're continuously helping improve. This isn't fast with her. She's not dropping it. It's taking time, but she feels it, and that's really important. How am I doing on time? Good? All right. Histamine and idiopathic symptoms. So 2 pathways in histamine, a lot of problems clinically. So you have a DAO pathway I'll be talking about, and then the HNMT pathway, that's your scratching and topical histamine. But the gut histamine is overlooked. Look at all of these symptoms you guys can see, and chronic disease is associated with it. I'll never be an expert, I feel like, with histamine. It's just so broad. But so many symptoms are related to it. From skin, heart, central nervous system, bone marrow issues, all right? White blood cell conditions. PMS, look at the uterus, all right? From histamine intolerance. And migraines. That's the key. So DAO is an enzyme in the gut, and it breaks down histamine, okay? So you can get diarrhea, yep, like IBS diarrhea, refractory to rifaximin and all the antibiotics if it's histamine. And people just genetically who have this, they can have low blood pressure, they can have dizziness. And these are the genes that I typically see with it, all right? AOC1, it leads to a predisposition to the inability to break down that form of histamine, okay? So in that diamine oxidase pathway, gut-related blood pressure, dizziness, headaches, all that stuff, okay? And supplementing with a supplement that can actually break it down and decrease levels by 50 to 70%. So we have a 38-year-old executive, no, not me this time. He presents to established care and mentions he has migraines. He doesn't care. I take 2 Advil a day, and I'm good to go. Is that good? Yeah, he was on the fast track to the ER and possibly elsewhere. So I had to tell him and his wife, that's not good, all right? He had a neurologist put him on magnesium and beta blockers. He tried it. He's like, I didn't like the way that beta blockers made my sex life, and yeah, it didn't even work. So he continued to pop the Excedrin, then he came to see me and we did the genetics. Lifestyle, unremarkable. Thin, healthy guy. He had 1 gene variant, a third of the population have. So I'm thinking now, right? We have the problem that's not getting solved, and we have a gene that could be expressing. So what do you think I did? I put him on diamine oxidase supplementation for 6 weeks, and I never heard back from him. You guys have that? Or you never hear back? Good news, no news is good news? So we call him like, dude, what's going on? You know, how are you? So he returns my call and says, you know, it's funny, I've been meaning to call you. I haven't had a migraine since. And I said, well, that would have been nice to let me know. And it's the first time he felt that way. So each year I check in on him now, 3 years completely migraine-free. I had another guy just like this recently. They thought it was too much estrogen because he was converting estrogen too much. And estrogen could do that, promote migraines. We see it in women. And sure enough, same exact thing. So when certain nutrition and lifestyle, all right, aren't enough, or we don't have answers, I find that clinical genomics can help solve that mystery. It's like you're missing piece to the puzzle, right? So it's kind of my little wellness triad: cognition, working out and exercise, eating right, and your genes to kind of put it all together as your path to longevity. Thanks, guys, and I'll take any questions. I appreciate it.
Again, remember that, recuerden que tenemos dos micrófonos, uno aquí y otro en el otro lado, para hacer preguntas. Dr. Martin.
Elliot, great talk. I have a question. Are you looking at all at pharmacogenomics? I'm thinking, we're using semaglutide, GLP-1s so much, and we know that some patients are better responders than others. I don't know if you've looked at that. Makes sense.
It's exactly what I was thinking. It's a cost barrier depending on the genetic testing that you're using, so the patients have to elect for it. I found in the case that I gave, if you remember her genes, we can even go back here. Actually, forget it. In her genetics, she was not a TCF7 individual.
No.
Right? She had other ones, and she didn't respond very well. She plateaued quickly. I suspect that would be an amazing study to do.
Yeah.
I haven't seen it in the literature yet, and I haven't looked into it. But if you have those variants, you kind of need it. So I think in people who have weight gain, it's a great question.
All right. Thanks.
Yep.